Symptom-Based Antidepressant selections. This strategy leads to the construction of a portfolio of multiple agents to treat all residual symptoms of unipolar depression until the patient achieves sustained remission. First, the symptoms are constructed into a diagnosis and then deconstructed into a list of specific symptoms, which are then matched with the brain circuits and their neurotransmitters that hypothetically mediate them. And finally, available treatment options that target these neuropharmacological mechanisms are chosen. For example, in a patient with symptoms of problem concentrating, decreased interest as well as fatigue, this approach would suggest treating both norepinephrine and dopamine with first-line antidepressants, plus augmenting agents that act on these neurotransmitters. And this can call for stopping the SSRI if this is partially the cause of these symptoms. This approach helps finding a faster way of reducing specific symptoms with more tolerable treatment selection for the patient than a purely random approach. This can also be applied to treating common associated symptoms of depression that are not components of the formal diagnostic criteria. 5 such symptoms are anxiety, pain, hypersomnia, problems with arousal and alertness, and sexual dysfunction. Therefore, to get the patient with major depression into remission, it requires targeting at least 14 of the 9 symptoms of depression. Anxiety can be reduced in patients with the same serotonin and GABA mechanisms proven to work in anxiety disorders. Hypersomnia is a common associated symptom of depression, but frequently not detected because patients who have this problem surprisingly do not often complain about it. Such patients may respond to the same agents that are effective in sleep disorders, such as agents that can boost dopamine, norepinephrine, and histamine. Painful physical and vasomotor symptoms are commonly associated with depression and can be treated with SNRIs and other approaches. Sexual dysfunction can be a complicated problem of many causes and can range from lack of libido to problem with arousal and lack of orgasm. Increasing dopamine or decreasing serotonin are the usual approaches to this set of problems, whether the patient has major depression or not. Parts of CNS with which these symptoms are usually associated with. Physical fatigue is associated with striatum and spinal cord, mental fatigue with loss of interest to DLPFC and nucleus accumbens, insomnia to hypothalamus, and concentration to DLPFC.